Firstly, I'm delighted to see you all here today. It's almost a full house, and when we organize these things, we never really know exactly how many people will come, because I've found that over the years we meet some new faces every year. So firstly, great to see some new people in the room that haven't been here before, but also I know there's again a lot of people who don't know about HAPS or are in need of something like this. So if you do know anybody else, please encourage them to have a look at this online after the event. So for those of you that haven't met me, my name is Pamela Scoffel. I am the board president for Houston Area Parkinson's, and it is, my extreme pleasure to be here. I too was a caregiver. I continue to be a caregiver as a mother, but I was a caregiver for my father who had Parkinson's disease, and it was always a journey. And I always talk about caregiving as being a journey. And as an athlete and as a mom, I've always talked about this idea of periodization. And periodization is about structuring your training and your performance for that one big day. And you may have many big days in the life of being a caregiver. And so you've got to pace yourselves as caregivers. And so some days may be good, and some days may be better, and some days may not be good at all. But you've got to realize that it is this long journey, and you've got to have these periods of uptime and periods of downtime. So I do appreciate the time that you've taken and the energy it takes to leave somebody behind today and to get yourself organized and get yourselves out of the house and to be here. I know that's an extremely positive thing to do, and I know you're going to give it your 100% in being here today. So before we get started, we can't do these things without the help of our sponsors. And some of them you met in the hallway today, but I would like to thank the following sponsors. We have the American Parkinson's Disease Association, we have Abbott, AbbVie, Adamas, Boston Scientific, Home Instead, Synovian, and US World Meds. And we're also sponsored from our silver section by Acadia Pharmaceuticals, Belmont Village Senior Living, Impacts, Medtronics, DBS, and UCB. And then finally, we have some great speakers here today. I know you've got the program in your packages. You're in for a great treat. And then we also have some wonderful staff who've given up their time to be here today. So thank you to all of our staff for making this possible. This is the 7th Caregivers Conference. I actually do remember the first one. I don't know if Kathleen does, but I worked on the registration table for the first Caregivers Conference. And Darcy, who's with me here today, my daughter, she was, just 1 year old at the time. And, over the years, I've gone from being a volunteer for this organization, so I want to thank all the volunteers who are here today, to being a board member and then to being a board president. And so, we are always in need of volunteers and board members. So again, I would ask you that if you have anybody in mind that you think would make a great board member or volunteer, please let any of the staff know here today. So without further ado, I'd like to introduce our first speaker of the day. We have the pleasure of having Michele York. Michele is an associate professor of neurology and section head of neuropsychology in the Department of Neurology at Baylor College of Medicine. She's had extensive training, including internships in clinical psychology, neuropsychology, and a postdoctoral fellowship in neuropsychology. Her specialties include evaluation of adults with movement disorders, patients with deep brain stimulation, and the differential diagnosis of dementias. She was awarded 2 Fulbright and Jaworski LLP Faculty Excellence Awards for Teaching and Evaluation in 2012, and the Norton Rose Fulbright Award for Teaching and Evaluation in 2018. She is also a member of the Academy of Distinguished Educators, which recognizes the educational scholarship of faculty members and the educational missions of Baylor College of Medicine. But more importantly, Michele is also a wonderful participant as part of our Medical Board of Advisors for Houston Area Parkinson's. Thank you, Dr. York, for all of your assistance here today, and I welcome you to the stage. Thank you.
Okay, so we're going to start the day off talking about what Parkinson's disease dementia is. And it may not be the happiest of subjects to start with, but we'll try to make it not I'm going to just start by defining some terms. That way we can all talk about it in the same exact way and know what we're saying when we say those words. I'm going to talk about the differences between normal aging, mild cognitive impairment and Parkinson's disease dementia, and then briefly about dementia with Lewy bodies, and talking about the similarities and differences between some of these. And then I want to try to focus quite a bit of the time on discussing some practical strategies for how to deal with some of these cognitive changes. So we know Parkinson's disease is a motor disorder. It's diagnosed by the motor symptoms of Parkinson's, of the disease. However, as you can see here on the slide, it's like an iceberg. There's all of these other symptoms, these non-motor symptoms that you can't see, but that the disease affects. So cognition is one of these non-motor symptoms, and that's what we're going to focus on today. There's obviously a whole host of other ones, and Dr. Shahed is going to be focusing on hallucinations in the next talk. So let's talk about some of those definitions, again, just so that we're all saying the same words and meaning the same thing. So cognition. If you think about cognition, all I'm talking about is thinking skills. It is anything that has to do with memory or how you see things or reasoning, judgment. Anything that has to do with a thinking skill that the brain controls is cognition. And in Parkinson's disease, a lot of times people don't think that cognition can be affected. And so one of the reasons to have these types of programs, educational programs, is to make sure everyone understands that this can be a part of the disease process. And then let's talk about it and see if there's things that we can do to help. And actually, these non-motor symptoms, in particular cognition, can be more debilitating to quality of life than even the non-motor symptoms, even the motor symptoms. Motor symptoms, we have some pretty good medications that can be helpful. We don't have any magic pills for the non-motor symptoms. I will talk about some treatments, though. So dementia. Everyone talks about dementia, and a lot of times they don't understand what it really means. So dementia is really an umbrella term. It just means progressive memory problems or cognitive problems, meaning it gets worse over time, and that it affects the person's activities of daily living, so that it impairs their ability to do things. And so there are many different kinds of dementia. So dementia is the umbrella term, and underneath that umbrella are there's probably at least 50, and we're learning more about different other types of dementia. Alzheimer's disease is the most common type of dementia. So 50% of individuals with dementia have Alzheimer's disease. But Parkinson's disease dementia is a different type of dementia, okay? It is not Alzheimer's disease, and I'm going to talk about that some more. So let's talk about just the cognitive continuum, meaning from normal aging to not normal aging, and over time. By a show of hands, who's ever in the room had a senior moment? Right? Okay. So, as you can see here, everyone raised their hands, right? So, senior moments, we all have them. I left my phone and my wallet at home this morning and had to run back and get it. We've all had them. So, when we talk about normal aging, there are some declines that occur. And actually, I'm going to tell you the bad news is starting at about 35 years old, it starts to be a slight downward slope. That's pretty sad, isn't it? Okay, so you've got normal aging here. And as you can see, for some folks, maybe they don't have a decline, but most people do. There's this little line here. Then there's, the blue line is also considered normal aging. But when you get into this range here, this is called mild cognitive impairment. And this is really the kind of the borderline in between normal aging and dementia. Okay, so there can be some preclinical stages that people don't, they may say, it's not as good as I used to be. But when it gets to here, people start getting concerned. Other people may say, memory's not as good as it was, or you may say to yourself, I know I'm kind of losing some things. I'm still able to do everything in my life like I was able to do before. When it gets down to dementia, that's where the cognitive impairment has started to impair the daily functioning. That is, maybe you can't do the finances anymore, or if you're planning a vacation, you can't kind of figure out how to put everything into sequence to get all the plans together. So that's where it starts to impede performance. Okay. So in normal aging, it's not like everything starts to go, right? When you thought of your senior moment, you probably thought of, I walked into a room and couldn't remember what I was going to get into the room. That's probably the most common. But there's a lot of things that remain intact in terms of normal aging. That does not tend to change over time. So this whole side on the left here are all things that really don't change with normal aging. On the other side, these are the ones that tend to start to decline. And it's in short-term memory, or that, again, the walking into the room. Maybe in word finding, where you know what you want to say, but it's tip of your tongue and you can't quite get the word out. And sometimes you feel like your wheels maybe just don't turn as fast. That speed of processing is a little bit slower than it used to be. So let's talk about this in terms of cognition, Parkinson's disease and cognition, because that other stuff was kind of normal aging and kind of how we all work. But in Parkinson's disease, again, Parkinson's disease dementia, or the cognitive changes in Parkinson's disease, is not Alzheimer's disease, okay? They can co-occur. It's very rare. So someone can have Alzheimer's disease and have Parkinson's disease. And the reason for that is that it's different pathologies that are occurring in the brain. It's extremely rare to have both, okay? So if you're talking about you've got Parkinson's disease and you have dementia, most likely that is going to be a Parkinson's disease dementia, or PDD, okay? Alzheimer's disease is, and people are kind of more familiar with Alzheimer's disease, it is severe memory changes that progress, and that's the first thing that starts to go, is the short-term memory. And then they also have impairments, usually sometimes in language, and other times in how their brain perceives what they see. And this does impact their ability to perform their activities of daily living. In Parkinson's disease, they can have memory changes and short-term memory changes, but they're usually not as severe as they are in Alzheimer's disease. And usually they have problems in what's called executive functioning. And executive functioning is, if you think of your frontal lobe, it's everything that is a higher order cognitive process, is what we call it. So it's things like reasoning, judgment, planning, multitasking. If you ever have to integrate information, which is what we do on a daily basis, what you're doing right now, you're using your frontal lobe. You're having to look at me and hear what I'm saying and understand. That's all different kinds of parts of your brain that are having to work together to comprehend what I'm saying. Okay, so in terms of Parkinson's disease cognition, over 50% of Parkinson's patients have cognitive changes throughout the course of the disease. And approximately 30% of patients with Parkinson's disease will develop Parkinson's disease dementia. Okay, so looking at this little pie chart here, this is no cognitive changes in Parkinson's disease. This one is Parkinson's mild cognitive impairment, and then this part is the Parkinson's disease dementia. Okay, so this is a pretty pervasive problem in Parkinson's disease. It's one that you can't see, right, unless you talk to someone and then can kind of pull out some differences that are going on. But it is occurring and over half of the patients. So it's definitely something we need to be able to talk about. You need to talk about with your doctors, and we need to see if there's things we can do to help. So again, in Parkinson's disease, not everything in terms of cognition is impaired. There are many things that people very far into Parkinson's diagnosis will continue to do very well on. They're still oriented, they still know who they are and where they are and what they're doing. They're able to store memory, but in Parkinson's disease, they have a harder time pulling that memory out. So that's where their short-term memory problem is. Their vocabulary and grammar usually remains relatively intact until much later on into a dementia process. And they're still the same bright, smart people that they used to be. They may not be as fast with the information and getting it out, but it's there. And if you give them time, that intellectual functioning is still there. So there are some issues that are impaired, though, and these are the ones that we need to help deal with. Again, that slowed information processing, where it's I always think of it as the wheels in your brain are just not moving quite as fast. Give them enough time and they'll get the response out, but it's going to take them longer. It's actually called bradyphrenia. Bradykinesia is when they have trouble moving, right? They have slowness of movement. Bradyphrenia is actually the slowness of the thoughts. The word finding, or the tip of the tongue phenomenon. Perception is that our eyes see, but our brain perceives what we see. And in Parkinson's disease, sometimes the areas of the brain that control that perception can be impaired. And so they may not see things the same way that you do, which can cause, obviously, a problem for things like driving. Working memory is very short-term memory. It's if someone gives you a telephone number and you have to try to remember the telephone number to then put it into your phone. It's those quick seconds of trying to keep that information in your mind. And then short-term memory, like we talked about. The last three there are problem-solving, multitasking, and reasoning. Those are all those executive functions that I was talking about that's housed up here in our frontal lobe. And those are the ones in Parkinson's disease that kind of sets it apart from other types of dementia, and particularly from Alzheimer's disease. So this is a listing, and it's in your handbook also, of different ways that executive functioning can impair someone's daily abilities to do their activities. So following a recipe, cooking actually is a complicated thing. Ask my children, because I can't cook. So you have to get all the ingredients out. You have to be able to put them into a sequence. You have to know and measure. So following that recipe actually can be a very complicated task. Finances, being able to pay the bills or balance the checkbook or do the taxes, all of these things can start to become impaired or more difficult if someone's executive functioning is not working. And in Parkinson's disease, we'll talk about multitasking quite a bit, because every activity that has a physical component to it for Parkinson's patient becomes a multitask, because we take our movements for granted. That's just an automatic thing that everyone does. In Parkinson's disease, when that becomes less automatic and they have to think about it, then anything that has a motor component with another task is then a multitask. They're having to do two things at one time. So in terms of safety issues, that could be a concern. So Parkinson's disease mild cognitive impairment. You'll remember that MCI category that was a borderline in between normal cognition and dementia. So this is where people start noticing that there are cognitive problems and there can be a concern, or others might be noticing it, but it's not really impeding their ability to do their activities of daily living. So this is a gradual decline. You have to have Parkinson's disease first, and then there's a gradual decline in cognition. One of these areas here, okay? And again, it doesn't impair their daily life. When we talk about Parkinson's disease dementia, again, you have to have a diagnosis of Parkinson's disease, and then the dementia, which is that progression of cognition over time, and it has to be in two of these different areas. So usually in Parkinson's disease, like I was talking about, it's in executive functioning, and then usually the other one is either short-term memory or it can be visual spatial functioning. Those are the kind of the main ones that tend to decline first in Parkinson's disease. And that's, slightly different when I was talking about Alzheimer's disease, where memory is the first thing that goes, and it goes pretty severely. And this does impede their daily life. So this is just another way of showing what is impaired and what is not impaired in Parkinson's disease. So again, it's executive functioning is probably the most impaired, but there can be lesser impairments in the other areas. So Lewy body dementia is different but similar. I think of Lewy body dementia as kind of Alzheimer's light and Parkinson's light, if you want to think of it that way. So in Lewy body dementia, they will have some Parkinsonian features. They may not be as severe or as noticeable as they are in idiopathic Parkinson's disease. However, the dementia or the cognitive issues begin very early on in this process, within the first year. So first year of having motor symptoms, they're starting to show cognitive decline. And the cognitive decline is more severe than what you would see in a Parkinson's disease dementia, early on at least. So the problems tend to be more severe in terms of memory, so that's why I call it Alzheimer's light, because it's got some of those symptoms of dementia with an Alzheimer's dementia, where the memory is more severe. They also tend to have very severe changes in visual spatial functioning, which is again your eyes see, your brain perceives. So they really, at the very beginning of the disease process, start having difficulties with that perception of what their environment looks like. They also have very severe, vivid, and well-formed visual hallucinations. And Dr. Shahed is going to be talking more about this, so I'm going to leave that expertise to her. But there are differences between these types of dementia. If you start thinking about it, just a kind of a quick rule of thumb is that first year, if there are motor symptoms and more severe cognitive problems that are impeding their ability to do their activities of daily living, it's not going to be a Parkinson's disease dementia. We're going to start talking about a Lewy body dementia then. And this is just in another way. And there are other features, and we can talk about those if you've got questions about it. So there are many features that can affect cognition. Stress, different medications, mood definitely can, sleep, which is a problem in Parkinson's disease, definitely can affect cognition. And those are things that need to be addressed with your doctors and treated if possible. And UTIs, urinary tract infections, can throw individuals who are having some cognitive decline for a complete loop. So if there seems to be an infection, that needs to be taken care of first. Most important thing here, talk to your doctors. So there are some approved treatments for cognitive changes in Parkinson's disease, and rivastigmine, which is Exelon here, is the one that has been FDA approved. The other medications are off formulary for Parkinson's disease, but there have been some studies looking at potential improvement in cognition, or at least staving off of further cognitive decline, so slowing the progression of the cognitive decline. And these are used in Parkinson's patients with cognitive changes. Okay, I want to make sure I have time to talk about the practical suggestions, partly because these are not all of them are just for patients with Parkinson's disease that are having cognitive impairments. We've got a whole room of caregivers here who don't have Parkinson's disease, and this is for you too. This is for all of us. These are things that we can do to help stave off cognitive changes in our own lives. So one of the most important things to do is to reduce vascular risk factors. So things like high blood pressure, high cholesterol, diabetes, smoking, obesity, all of these things that we know are not good for our hearts, we need to make sure are under control. So talking to your doctor, making sure you're on medications to reduce these if they are a problem for you. Exercise, the bane of my existence, but I still do it sometimes because it does have amazing effects. We know the research shows that exercise increases blood flow. It's good for your mood. It's good for your brain. It's good for your heart. It's good for just about everything. So as much as some of us don't like to do it, it is still good for us, and we need to do this because it can actually help our cognition and stave off changes. Again, the list just keeps going on as to how important it is to exercise. And we are so blessed that in Houston we have HAPS that has all of these amazing free exercise programs for our patients with Parkinson's disease. So that means y'all don't have an excuse not to go. And seniors who exercise 3 or more times per week were 60% less likely to develop dementia. And just think about that. That is an amazing statistic that really tells us we all need to go exercise. So I'm going to put in a plug again for HAPS and the marathon, that this is a great way to get out and exercise and have fun with HAPS. And I know I still haven't signed up. Okay, another way is to socialize. So what you're doing right now, and you'll be doing when you go out and get food and we have our breaks, is one of the most complicated and complex things that we do, and we take it for granted. But having social interaction makes all of the parts of our brain light up. We have to, again, you have to think about what the person's saying, you have to pay attention to them, you have to comprehend, you have to talk, you're watching me as I'm moving my arms all over because I'm Italian. There's so many different things that go on with social interaction that this is one of the ways that we can really help our brain and keep it active. When people retire and then sit in front of the TV and stop interacting on a kind of daily basis, you can start to see cognitive changes. Those who get out and keep on doing things and interact with folks, it doesn't have to be complicated interactions, just having fun, can keep those brain and those neural cells working. So again, we are pre-programmed as humans to interact. So this is something that we really need. Our brains actually want it. Even me as an introvert who doesn't like to be around people all the time, still I crave it at times. My brain craves it. So it is very important that we continue with social interactions. Now, if someone's having cognitive issues, social interaction can be difficult. And I'm not taking that away. But you can put limits to social interaction that can still get them out and having fun and being around other people, but in a way that they can feel comfortable with. So instead of going to a noisy restaurant that has, too many tables all packed together, try to go to one that maybe is less crowded and only go with one other couple. Don't go with a whole big group of people. And if the other couple maybe does understand that there can be cognitive changes, they can help with conversations at that point also by drawing the person in. So asking a specific question to a person and waiting for the response is a way to make sure that they're interacting still. Or saying, we're talking about, and whatever it is, and giving context so that the person can then understand what the conversation's about and giving them time to respond to it. So like I said, we talked about those wheels not being going as fast. So you may have to be patient. It's a virtue that I work on constantly with my 3 teenagers. But it's something that if you spend the time can be very helpful to a Parkinson's patient. Again, we talked about that intellectual functioning is still there. There's that same bright person is still in there. It just takes them longer to get it out. So you might have to wait a little bit longer for the response. Avoid interrupting them, because if you interrupt someone as they're talking or as they're doing something, it becomes a multitask then, right? Then they have to kind of stop what they're doing, do the other thing, respond to you, and then go back to it. So, and that each one of those steps can take a whole lot longer. So we talked a little bit about sleep, and sleep is so important to our cognitive function. Sleep is when our brain restores itself. It's when it consolidates what we've learned that day and puts it into storage for us to use the next day or later on. So sleep is so, so important. And who here gets 8 hours of uninterrupted sleep per night? So there's There's maybe a handful of y'all. You remember how many hands went up for the senior moments? A little different. So again, sleep is so important, and in Parkinson's disease, there are so many different sleep issues that can occur. Some of them can be helped with some medication, so it's very important to talk to the doctors about sleep and what's going on and seeing if there's a way that they can help. And lack of sleep also affects our mood, and you can actually ask my children about that one also. So this is a cluttered desk is a sign of a cluttered mind, or one of my favorite pictures is, in quotes, is if a cluttered desk is a sign of a cluttered mind, of what then is an empty desk a sign? And I'm pretty sure this is Albert Einstein sitting at my desk at Baylor. So it's very important to reduce distractions around the house and to help your loved one with Parkinson's disease, giving them structure. That structure can help them still be able to do things, not in the same way maybe that they were able to do it before, but in a way that's new and still that they can maintain some independence. A routine is just key to this, keeping the same routine. Now, obviously, you've got doctor's appointments and other things that are coming on, but if you can get up at the same time, breakfast at the same time, lunch at the same time, as long as you try to maintain a routine, that can be helpful for them in kind of just keeping everything going in a way that they understand. Sticky notes are fantastic things on your phones, any kind of lists of activities of daily living, things that are written down that they can go back and look at. A lot of times men can carry in a pocket a list of what they have to do that day, and as long as they can remember to look at the list, then maybe they're not asking you every 5 minutes what it is. They can just pull out their list and say, okay, this is the next thing on the list. And because of Parkinson's disease on and off times, and that it tends, as people get fatigued, their motor symptoms tend to get worse, and actually their cognition also tends to get worse. Planning kind of when you do more complicated cognitive activities can be very helpful. So if they're better in the morning, and that's when they're on, then trying to talk about vacation plans in the morning versus when they're exhausted in the evenings and maybe they're off. So just thinking about your loved one and when their best times are, and not only planning physical activities for that time, but the cognitive activities. So we talked a little bit about that multitasking and that. So this guy right here is, if you think about it, you wouldn't necessarily think this is a multitask, right? But for someone with Parkinson's disease, he is walking downstairs, he's talking on the telephone, and he's carrying something. That right there is a safety no-no. Don't do that with Parkinson's disease, right? One thing at a time. Anything with a motor component, even if it's holding a glass of water while walking and then going to turn the doorknob on the handle, door handle, can be a multitask, is a multitask for someone with Parkinson's disease and can cause a safety issue. So again, providing structure, there's all the information is in there, but just asking a question instead of, what are you in the mood for dinner? How about, do you want rice or pasta with dinner? So that it's not, they have to think about every option that's out there. They have to narrow it down to 2 options and pick one or the other. So I actually do this. I talk out loud all the time. People walk by my office and think I'm crazy. I am not, Julie, I'm not talking to other people other people don't see. But when I tend to set things down and forget where I put them. So I will say, I am setting my glasses on my desk, and I will put them down. Because if I hear it, it's another way for my brain to then remember what I did. So when you meet someone, they tell you you should say their name out loud. So it's nice to meet you, Kathleen. It's nice to meet you. And that way, that is another way for your brain to get that information when you need it later. It's another retrieval cue for you. And we all use compensatory strategies. We all need our phone. We need reminders. We have timers on our pill boxes. Everyone uses compensatory strategies. Without my phone, I don't have a brain, right? I have to go looking, I had to go back and get my phone this morning before I came here, because without that, I'm lost. And there are so many different ways, so we might as well use them. That way it's taking the pressure off of your brain that you have to remember that information along with all the other information. Let the phone or the planner do that work for you. So there is the old adage, if you don't use it, you will lose it, and that's the same for the brain. So there are some high-tech brain stimulation games that are out there. Lumosity is one that you can get on your phone. I only recommend these if you like them. If you don't like playing these types of games, then don't do it. Do something else. Be around people. But I wanted to let you know that there are some out there. And the mental activity has to be stimulating. So just staring at a computer or just surfing the internet without actually learning something, or staring at the TV or flipping the channels, that's not mentally stimulating. It has to be something new, something that you're learning, something that you're really trying to get your brain to focus on. And there are so many different things out there that you can do. And I have a whole listing of some things, but there are so many of them. And HAPS in itself offers any particular day, pick a day, and you can go do some kind of mentally stimulating activity. So, and I think it's important to, not only for you all who are in the room, but for you to think about what your loved one with Parkinson's can do. Instead of thinking about what they have trouble doing because of their movement disorder, what can they do? And then focus on those abilities, not the disability that they can't do. So this is I always love to show this woman. Her name is Peggy Chun, and she was an artist in Hawaii. She actually has ALS, or had ALS. And this was one of her regular pictures that she had painted. She lost the use of her her right hand that she painted with, and she started painting with her left hand. And this is a picture that she painted, which I think is absolutely beautiful. She then lost her ability to use both of her hands and started painting with her teeth, along with a program that she had. And again, different than it was before, but still a beautiful painting. She actually lost the ability to keep the paintbrush in her mouth and started painting with her eyes using her wheelchair and her eye tracker. And again, different than her original painting, but just as beautiful. And I think just shows that focusing on what you can do and not on what you can't do, you can continue to do an activity that you absolutely enjoy. And I think the very most important thing is for everyone in this room to realize that you must take care of yourself. So I talked about how you can help your loved ones, but you are the ones that are helping them do all of these activities. And if you're not taking care of yourself, and if you're not there to help them, then all of this is for naught. So the most important thing for you to do is to make sure you're taking care of yourself.